Good morning, everybody, and thank you for inviting me to speak even at 9 o'clock on a Sunday morning. Looks like it's been a very successful and a very informative conference. Before I start, I just want to tell you a little story. I was chatting to three of my perimenopausal colleagues, and Carmen, I'm not looking at you. And they're in the perimenopausal fog, and one says the other, I was looking through my daughter's drawer, and I found some cigarettes, and she said, I didn't know she smoked. And the other one said, well, that's nothing. I was looking through her drawer, and I found some alcohol. I didn't know she drank. And the third one said, well, I was looking through my daughter's drawer, and I found some condoms. I never knew she had a penis. So we're going to talk about perimenopausal bleeding, and as you all know in general practice, it is a bloody mess. There's no conflict of interest. I do get a speaker's honorarium. I am not affiliated with any pharmaceutical companies. I'm not getting any grants. There's no potential for bias, and I'm not retiring anytime soon. So what are the objectives of today's talk? We want to find out what the underlying causes of perimenopausal bleeding are, especially abnormal perimenopausal bleeding. We want to look into who do we investigate and treat, and what are the relevant investigations, and also the treatment options, and all three of us will be talking about that, and we're going to do that all in 15 minutes. So when we look at the perimenopausal phase of a woman's life, it's a transition from the reproductive phase of her life to an anovulatory hypoestrogenic state. And there's no absolute time definition. It's a transition. Usually starts in the mid-late 40s, and menopause in North America occurs at around 51 years old. So perimenopausal bleeding, when we look at it, it has to be looked in the wider context of what else is happening in the woman's life. It's not only about the bleeding. Is she having menopausal symptoms? Is she depressed? Health issues, midlife medicine, marital issues, occupational issues, etc. So why is it a problem? Because, as we all know, it affects quality of life, not only occupational, social, but sexual health as well. And we all deal with the walking worried. Is this cancer, doctor? I've had an abnormal period. Do I have cancer? It really can be a sign of endometrial hyperplasia. And some of the bleeding can be a sign of other pathology in the pelvis. So this is a sign of underlying pathology. So briefly looking at the etiology, probably the most common cause of abnormal perimenopausal bleeding is related to anovulatory cycles. And going back to Gynae 101, the follicle in the ovary produces estrogen in the first part of the cycle, produces estrogen, which causes the endometrial lining to become nice and thick and juicy, waiting for a pregnancy. After ovulation, they produce progesterone, and it's the progesterone which comes along and binds the endometrial lining. It stabilizes it. And if there isn't fertilization, the corpus luteum function disappears, the progesterone level drops, and as the progesterone level drops, it sloughs off the endometrial lining in an organized fashion. So patients that don't ovulate have a lot of unopposed estrogen causing the endometrial lining to proliferate, get thicker, and eventually become so thick that it becomes unstable and breaks down in an irregular fashion. You can see that in the top right-hand diagram. And this produces prolonged bleeding, unpredictable bleeding, and heavy bleeding. To complicate matters, we have another type of bleeding. This is psychical bleeding, and all of you have sort of come across this when patients say, I'm still having regular periods, but they are very, very short. They're happening between every 14 and 21 days. And this is a pathology in the hypothalamus. There's the hypothalamic pituitary axis goes a little wonky, and there's a positive feedback from estrogen. So these patients are ovulatory, but they're having very short cycles. And they go from one period into the next. And then we have the anatomical causes, the large fibroids, polyps in the endometrial cavity, polyps on the cervix. Iatrogenic causes, we shouldn't ignore this. Lost IUDs, I've seen a few of those. Over-the-counter hormonal and nutritional supplements. Some of them have phytoestrogens. And a lot of these patients are taking a lot more estrogen than we think they are. And then other medical diseases, coagulopathies, hypothyroidism, medications, anticoagulants, PCOS. But these are usually long-standing issues. They're very unusual to present in the perimenopausal phase. So who needs to be investigated and who needs to be treated? Basically, I said to you all, treat the patient, not the piece of paper. Everybody sweats the ferritin. I get lots of referrals. She's doing fine, but we did her CBC and her ferritin is 5. Hemoglobin's 140, but her ferritin's 5. Don't sweat that. Look at the patient. So I treat patients that have symptomatic anemia, feeling really run down all the time, loss of energy. If they have large fibroids, there's lots of causing pressure symptoms, urinary frequency, difficult with bowel functions, intimacy problems, they need to be investigated and treated. And if you're concerned about the patient's risks for endometrial hyperplasia, obese patients, diabetic patients, they need to be investigated. Now, when it comes to taking your history and determining how much bleeding is too much, because no woman says my periods are just fabulous, they're 7 days long and just brilliant. What are the two? I use these two questions to ask who really, how much bleeding is too much. And the first question I ask is flooding. Do you have flooding? And flooding is, when they're soaking through pads and tampons at the same time, and they have to wake up 2 or 3 times at night. They're having embarrassing situations. They're in a meeting and they can't stand up because the chair's full of blood. So flooding, and then not clots. So clots the size of the palm of the hand. That's an indicator of fairly heavy bleeding. So what investigations do we do on these patients? And as always, we take a complete and thorough history, right? Just as we did in medical school. And the bottom line is we want to find out who's having ovulatory cycles versus anovulatory cycles. We want to find out, are they having regular periods, or is this bleeding unpredictable and prolonged? And you want to do a full medical questionnaire as well. And then we do a thorough exam, including a pelvic exam. We want to look at the body habitus. Is this patient obese? Does she have hypertension, etc.? We want to look for cervical polyps, and does she have a large pelvic mass? And probably the most useful, the take-home investigation is the pelvic ultrasound. That's more useful than a clinical pelvic examination, I feel. In gynecology, the pelvic ultrasound is better than the CT scan or the MRI. It's up close and personal. We usually recommend a transvaginal ultrasound. So this ultrasound is right, the probe is right at the anatomy. So a pelvic ultrasound is pretty much all that you need. Labs, we do the CBC, TSH. Don't forget a pregnancy test if there is a possibility that the patient could be pregnant. The luteal phase progesterone, I do not think is very helpful. LH and FSH, everyone orders them, and I'm guilty of doing that. It is a useless test. It is a useless test unless the patient is considering getting pregnant in her mid-40s, which is not going to happen. But it doesn't tell us anything. We know that the FSH is going to be above 10, and it doesn't tell us, it doesn't predict when menopause is going to happen. So it's a useless test. And then we come to the endometrial biopsy. So the question is, who do we need to biopsy? Now, in the literature, it says up to 25% of patients present with endometrial hyperplasia in the perimenopause. And this I don't see this in my practice. But I think in the excited states of America, where everyone is overweight and has diabetes, I think this might be more of an issue there. So looking at the Canadian guidelines, the SOGC recommends that we biopsy patients with abnormal bleeding, which is unresponsive to treatment. So these are patients who come with abnormal bleeding after age 40. We've tried treatment, they haven't responded. Those are the patients you want to biopsy. But you wouldn't be faulted in biopsying a lot of patients with abnormal bleeding who are younger, who are at risk for endometrial hyperplasia, as we said, obesity, hypertension, diabetes, patients with a history of colon cancer in their family that could represent a risk for Lynch syndrome, and patients who have a prolonged history of anovulatory cycles. And then as far as the postmenopausal population is concerned, postmenopausal bleeding after she's been amenorrheic for a year, who presents with bleeding and on ultrasound the endometrial stripe is greater than 5 millimeters. Those patients should be biopsied. The treatment, we'll talk about the various modalities of treatment. So who do we treat? I think if the patient is symptomatic, just treat everybody. Treat everybody medically. There's no harm in treating patients. Some of us feel we shouldn't treat patients with fibroids medically, they need surgery. I don't think that's correct. I think we can get by treating a lot of these patients medically and get satisfactory results. So who do we refer on? Patients with obviously large symptomatic fibroids unresponsive to treatment, patients who in general are unresponsive to medical treatment, and patients who need biopsy that you're unable to do in the office. Now we'll talk about what treatment options are available to this group of perimenopausal bleeders. So watchful waiting, conservative management, sure, it works. I wouldn't recommend it for more than a few cycles. Patient tends to get frustrated. But just asking her to keep a menstrual diary, sort of estimate how much blood she's losing, start her on some oral iron supplementation isn't a bad start. At least you're making her do something. Then we move on to medical treatment, and we'll go through each one of these options. Surgical options we won't talk about today, but the surgical options include endometrial ablation and hysterectomy. So tranexamic acid and cyclopentone. I think this is the most underused treatment when managing perimenopausal patients. This acts on the coagulation cascade pathway. It's an antifibrinolytic agent. The dose is simple, 1 to 2 pills 3 times a day. Very simple. It can be used if the patient has fibroids, polyps, whatever. It does reduce bleeding. It's not brilliant in stopping heavy bleeding, but it definitely does reduce the amount of blood flow. The big selling point is that it's non-hormonal. You say to the patient, this is non-hormonal treatment, doctor, sign me up for that. You use it on the heavy flow days, so it's a very short course of treatment. Has very few side effects, and it does not increase the risk of thrombosis. There was some concern some years ago that this could increase the risk of thrombosis. It does not. So it's short, sharp, to the point, cheap, used on the heavy flow days, very few side effects, non-hormonal. I think that would be your first go-to option. Anti-inflammatories, I mention them because they really don't work. They really do not significantly reduce the amount of bleeding, but they are good for patients that are having dysmenorrhea. The combination contraceptive pill, I think this is often the most commonly used treatment of perimenopausal or abnormal bleeding. The advantage is that it does do a very good job in stopping prolonged and ongoing bleeding, particularly in patients with anovulatory cycles. It has estrogen, progesterone, stabilizes the endometrial lining. We do the 21 days, the few days off, we have a withdrawal bleed, sloughs off the endometrial lining, and that really stops the bleeding. It is better to be used in patients with anovulatory cycles versus patients who have who have ovulatory cycles and abnormal bleeding from fibroids, but does a fair job in patients who have fibroids as well. The advantage is it reduces the amount and duration of bleeding. It also reduces menopausal symptoms, and this is one reason for using it in the perimenopause, particularly in patients having irregular cycles and menopausal symptoms. It also provides contraception for those patients who need it and prevents ovarian and uterine cancer. Disadvantages can cause breakthrough bleeding. Very few patients in their 40s want to take more hormones, and often can interfere with other medications that our patients are taking, antihypertensives, antithrombotic agents. And the biggest thing is side effect. No 40-year-old woman wants to gain extra weight and be more bloated. The Mirena Iud, I think we all know how this thing works. It's a device we insert inside the endometrial cavity, releases a small amount of levonorgestrel. The advantages is that it does produce amenorrhea. The manufacturers say about 80% of women are amenorrheic within 6 months. I don't find that, I think that number is a little bit exaggerated, but it does a good job. It has a low side effect profile. It's easily reversible. There are no compliance issues. It's in. I don't need to remember, did I take the pill? Didn't I take the pill? It also is effective in reducing blood loss than the oral agents. In patients that are having perimenopausal symptoms, the Mirena Iud does a fair job in reducing some of these menopausal symptoms. And if the patient does have Mirena Iud in place and does develop menopausal symptoms, flashing, night sweats, etc., hey, just add some estrogen. It's all good. You can use it in the presence of medium-sized fibroids. If the cavity is larger than 12 centimeters, this IUD is not going to be effective. I've spoken to some of my colleagues and patients that are resistant, who don't want to have surgery for these large fibroid uteruses. You can put more than one IUD inside the cavity, but I don't think that's a smart thing to do. And importantly, it's not contraindicated in patients with medical contraindications to using estrogen, such as patients who are hypertensive, have risk for thrombosis, etc. Disadvantages: it's expensive, it's difficult to insert, it can cause irregular bleeding, especially for the first 3 months. I think this is probably the biggest reason for discontinuing the use. When compared to surgical interventions such as ablation, it produces more bleeding, but the patient satisfaction is about the same. One of my colleagues will talk about oral progesterone in a bit more detail, but oral progesterones, we use them a lot. The take-home message with oral progesterone is as follows. You can use Provera, Prometrium. In patients with ovulatory cycles, patients that are having regular periods, we often add progesterone in the last 7 days of the cycle. It does not work that well. If you're going to give progesterone, it is better to give it for the full 21 days. That produces significant reduction in bleeding. The problem with that is the high side effect profile. So if you're going to give progesterone, give it for the full 21 days in an ovulatory patient. In patients that are having irregular anovulatory cycles, giving it for 7 to 10 days in a cyclical fashion does stabilize the endometrial lining, flush it out, and does a fairly good job in controlling abnormal perimenopausal bleeding. So when you compare the Mirena IUD to oral progesterones, the Mirena is more effective in reducing bleeding and has a higher patient satisfaction. Very few of us use Depo-Provera anymore. It can be used as one of the treatment options. It does provide contraceptive benefit. It has unpleasant side effects, difficult to reverse. The concern was about bone mineral density, decrease in bone mineral density. This is a reversible loss and picks up over time. So that's not one reason not to use it. I think all the other reasons, the poor side effect profile is the reason why we don't use the Depo-Provera. Now, the uterine artery embolization procedure, this is not for the faint of heart, and this is not just a little thing. Although it's not a surgical intervention, it does have significant side effects. Yes, it does reduce perimenopausal bleeding in patients with uterine fibroids. In patients with no anatomical pathology, it's not a good modality of treatment. So it is not to be used in patients who don't have fibroids. It is not to be used in patients that are considering fertility. It should be used in women who have symptomatic fibroids who do not want to have surgery. And the side effects can be fairly significant. It can produce pelvic pain syndrome, heavy vaginal bleeding requiring a hysterectomy. Surgical options, we have two options: the endometrial ablation, which is a day surgery procedure. There are different ways of doing it. We can resect fibroids, cauterize the endometrial lining. We can do this with the old electrosurgical method, and there's a number of other methods. There's a hot water method and ultrasound and microwave technologies available. This is something out of your scope of practice. And then lastly, the good old hysterectomy, which is still a good procedure. It is a good procedure. The big question in the perimenopause is, doctor, do I need to have my ovaries removed? And I feel they do not. I think I preserve ovaries until mid to late 50s, but I do remove their tubes because, as we know now, that ovarian cancer actually starts in the tubes and not the ovaries. So if they're going to have the hysterectomy, I remove their tubes, but not the ovaries. So if the patient comes back to your office and says, Dr. Rosengarten's going to keep my ovaries, what do you think of that? Say, yes, we're going to keep the ovaries, and he'll just remove your tubes and you will not get cancer. And that picture comes from a series of photographs called The Last Photo in the Camera.
Good morning. Thank you. Thank you for having us here to share our unique perspective. For the past 11 years, we've done nothing but, we did general practice before that, but nothing but hormones, believe it or not, perimenopausal and menopausal women. And through that experience, we've gained and acquired a lot of pointers about what women want, what they need, and what they're scared to talk about with their doctors. So I hope you enjoy a little bit of clarifications and maybe some answers to your questions that patients ask of you. Did you take the, oh, here it is, thank you. So first of all, I have no conflict of interest or commercial interests of any kind. I have no disclosure other than a small honorarium for this talk. The learning objectives that we want to talk about today are, first of all, we want to look at the nomenclature, first and foremost, looking at how the medical and the layman define hormone therapy, the source of hormones, the chemical and hormonal binding complexes, the pharmaceutical and compounded aspects of hormone therapy, and just briefly, because of time, some guidelines that NAMS and SOGC are currently suggesting. So why and when bioidentical terminology began? Well, in 2002, when the WHI was released, the Women's Health Initiative, it was a huge turning point in hormone therapy. And patients were told after years and years of hormone therapy, you must stop. We have risks now for breast cancer, for heart disease. And women had been on hormones for years, Premarin and Provera. And so doctors dropped them sometimes like hot potatoes because there was no other option. What could we give them? What could we do for them at that time? And around that time, there was a huge demographic of menopausal women who were very well-informed consumers who were going through menopause. And they said, well, you know, all you're offering me is sleeping pills and antidepressants. And certainly we can verify that the prescriptions for sleeping pills and antidepressants rose dramatically after the WHI report. And so patients started to search the internet and they found bioidentical hormone therapy. And this hormone therapy actually began here in Vancouver 2 or 3 decades ago by a pharmacist who was the original owner of Crips, and he worked with some physicians in the Northwest, and they together coined the term bioidentical hormone therapy. So you take this void that we have for patients, you take the need, and suddenly the internet, everything just exploded. Patients started ordering bioidentical hormone therapy online. They were going to various health providers and getting hormone therapy. And we as doctors were aghast. We said, wait a minute, there's no randomized double-blind placebo-controlled studies. There's no batch testing. There's no quality control. There's not even a peer-reviewed article on this. And so we were quite disturbed by the fact, but patients said, but doctor, I feel better on them. You're not giving me any options. What am I to do? So we, as a clinic, began to look at this very carefully. So bioidentical hormone, that term, you will not find, when you go into medical literature or into PubMed, you won't find that terminology. What it means is biologically identical to the human forms of hormones that we produce. The more correct term that you can find in medical literature is molecularly identical, or molecular equivalence. And that is what we use in medicine. And you'll see that in a lot of the published literature. And many peptide hormones, such as insulin, thyroid, and growth hormone, are all engineered to look like the human forms of our own hormones. And that is really a synonymous term then for bioidentical hormones. And we, as physicians, and I was one of them, when the patient would come in and say, I read Suzanne Summers' book and I'd like to go on bioidentical hormone therapy, the gut reaction was, oh my goodness. But if we just think about what their terminology is versus what we understand, they mean the same thing. What we need to look at, one of the factors when we look at bioidentical hormone therapy or molecular identical, is looking at natural and synthetic. Natural is when you have not changed anything, you have not modified anything in nature, you take it as it is. For example, Premarin is from a pregnant mare's urine, it's very natural. The hormones that we're using now, they come from natural sources such as yams or soybean, but we chemically purify them, then synthetically change them in a lab, and they're basically engineered to look like our hormones. So yes, they're from a natural source, but they are synthesized in a lab, so they look like our estrogen or our progesterone. Now, when I was doing research, an interesting tidbit was 3,000 years ago in the Chinese dynasty, one of the emperor's wives she was going through menopause, she had hot flashes, she was very, very distraught, and it was one of his favorite wives. So he called all the advisors into the room and he said, "You must find a cure for my wife. She's just not the person I know." So all the advisors were locked into a room until they came up with a solution. And one of the advisors was looking out the window and he saw a bunch of teenagers playing in the courtyard, and he noticed they were full of vitality and vim and vigor, and he said, the diet is the same. What are they doing differently? So he had a bright idea. He collected the urine of these teenagers, put it on some slabs of rock, and dried up the powder, made a potion, gave it to the emperor's wife, and lo and behold, she felt fantastic. She felt great. And so that was natural, and it was molecularly identical. I'm not inferring that you go and collect your teenager's urine. As Mark was talking about teenagers, I'm not sure what you'll find in teenagers' urines these days. The very important thing to think about when we think of hormone therapy is the lock and key analysis, how hormones attach to the receptor. The receptor is a very specialized protein. It has an affinity for a molecule. And the more closely that molecule can fit into the receptor, the higher the affinity. So our receptors for hormones have a very high affinity for the molecular identical hormones, obviously. But many others can come in, sit in that receptor site, and mimic the effect and attach to that protein and still turn on genetic switches in that tissue. So when you look at the molecular structure, and I had to go back to my pharmacy books and look through our sex hormones, our steroid hormones, they're derived from cholesterol. There are 3 benzene rings, and that is what's common to all of them, and that's what infers what we call the lipophilic quality, so they can penetrate through the skin and be absorbed. And if you look at estradiol, testosterone, progesterone, they all look very similar, and just small variations in the methyl group or hydroxyl group or adding a double bond of oxygen, very small chemical variations have very big effects. As we know, estradiol and testosterone are very, very different in their outcomes and effects. So when you look at, our colleagues have talked a little bit about progesterone, and Dr. Dhawan is going to elaborate more on progesterone, but we have the identical and non-identical, and they resemble each other with the benzene rings, but again, the effects are different. Same with estrogen. When you look at the third diagram there, that's 17-beta-estradiol. The other ones are equine estrogen. Again, at first look, you think they look very similar, but chemically they do vary, and they do have different outcomes, not just at the way that they affect the tissues, intracellularly and in the body as well. Another factor that has to be considered when we look at hormone therapy is the economics. Pharmaceutical companies cannot patent anything that exists already in your body. It's not a new drug. So we're not ever going to have huge trials on molecularly equivalent hormones. There's no funding for that. But what pharmaceutical companies can do is they can be very clever in designing delivery systems. So there are designer delivery systems for our hormones. What I'm showing you are FDA-approved standardized hormone therapy for estrogen that is available to you, and they are molecular equivalents or bioidentical hormones. The first one is Estradot, or Climera, and it's a very clever way to deliver a drug. 17-beta-estradiol is infused into the membrane matrix, and it's rate limited, so a certain amount is transmitted through the skin on a daily basis, 3.5 days or 7 days, depending on what you choose. The second product is a sachet. It's a gel with 17-beta-estradiol, our human estrogen, suspended in alcohol gel. The alcohol then evaporates, and 17-beta-estradiol crosses the skin barrier. It's very portable, and it does come in different doses. The third one is a metered pump, which you may be familiar with. It's been around for almost 15 years, Estrogel, and it's 17-beta-estradiol, and it can be, it's a great product, but sometimes when you want to customize the dose, you have difficulty because one pump is metered, but you can't do 1.5 pumps. Sometimes you don't want systemic therapy. Those 3 products I showed you are absorbed systemically, but you might just want vaginal treatment. The opaque ring that you see, that's called estring, is wonderful for a couple of reasons. One, if they just have atrophic vaginitis that's severe, or sometimes when patients are young and they've been chemically induced into menopause, they have a breast cancer, and patients are very scared, and so are doctors, to give them hormones. They might do well with just having intravaginal applications of these hormones. And this is a ring that stays in for 90 days, and every day 7.5 micrograms are secreted into the vaginal vault, and it has almost complete reversal for the vaginal epithelium when you look at it under the microscope. So it's 17-beta-estradiol. The second product is Vagifem, and that is 17-beta-estradiol for the vagina, and you put one tablet twice weekly for maintenance, and it's a great product as well. So it can be used, just for atrophic vaginitis in a menopausal woman or a younger woman who just has atrophic vaginitis. Very little systemic effect. The dose of Vagifem has been reduced recently. The third product is Premarin Vaginal Cream, and that's been around for many, many years. They also recently reduced the dose of it because we were getting some systemic absorption, and it's a great product for, urogenital atrophy. But when patients say, I want bioidentical, I want molecularly equivalent, well, you can tell them this is natural, but it's not molecularly equivalent. Some patients have an issue because they're animal lovers and they don't want a pregnant mare's urine. But in the US, they do have a 17-beta-estradiol cream called Estrace. We don't have that in Canada yet. The oral route and the transdermal route are very important when you're looking at molecularly equivalent hormones. Premarin and Estrace and Ogen. So those are the three products. Premarin, as you know, has been around for years, but all oral tablets, all oral estrogens are going to go through the liver, so they go through the P450 cytochrome system, and that infers some changes in the proteins. It reduces your sex hormone binding globulin, and also it is more procoagulant because they make prothrombin and procoagulant factors. So while patients want molecular equivalency, and that is important, and I guess, after all these years, we should question why we didn't think of this sooner, we also have to question the routes of administration. So transdermally, you bypass the liver. It allows you lower dosing. Sex hormone binding globulin is not compromised. And pharmacokinetically, when you give something orally, you know that as soon as you ingest it, you're going to get a very big peak in the drug and then a trough. Whereas through the skin, through the transdermal, you can get more of a steady state level. You're not getting the big valleys and peaks, and you get a better outcome that way from symptom relief. Less procoagulant factors and lower triglyceride levels. The contraindications for oral estrogen therapy are very similar to oral contraceptives. We now know through the WHI and then scrutinizing the WHI and a few other trials that have now come out since that hormone therapy is no longer considered a risk for breast cancer. But if you have a pre-existing breast cancer, certainly you must stop the hormone therapy. There's a really good study in Europe that they've been doing, the E3N study. We're waiting on results on that. But I think the trend is now, the pendulum is over here, whereas 12 years ago it was over here. Don't use hormones. Now it's use hormones carefully, but you can use them and use more discerning measures to look at the routes of delivery. High triglyceridemia and heavy smokers are also contraindications for oral therapy. So we looked at some of the FDA-approved ones, the samples that I showed you in the photos, and they are standardized, they're clinically tested, and they're available at every pharmacy. The patients that may come to you, this is the ones that are going to give you a little bit of grief. They'll say, well, no, we want bioidentical hormones that are compounded and customized for me, that are made just for me. So, having some knowledge about this is very important. The compounded hormone therapy, compounding, first of all, has been around for years. In pharmacy, we compound prescriptions for skin and other products. That's not unusual. The hormones are sourced from the same plant as, say, a company like Sharing would get, or, Estradiol, Clemera. They all source it from two plants. They're USB, progesterone USB or estradiol USB. So they do source it from that area. The problem is that if they get prescriptions from a naturopath who are licensed to give them bioidentical hormones, there isn't a lot of monitoring. There's no pap smears because naturopaths can't do pap smears, no breast exam or pelvic exams. So if we don't open up to our patients will go to the internet. They will go to other places where they may not be as safe. So it's important to educate them. When they ask for the customized products, 99% of our patients are on the FDA-approved ones. There are very few that we will compound for, and we work very closely with a compounding pharmacist who has all the right things in his pharmacy, a sterilized hood. We make sure they do batch testing. We make sure they're using the right bases. We make sure that they're quality controlled. But it's very difficult to control it because we don't know once we give a prescription to a patient where they're going to take it. So it's very important to educate them if they are going to choose this route. And we would prefer the FDA approved once they listen to the fact that you're open to it, choose that. And we have all these options that we didn't have before, so it's very important to let them know that. So conventionally, Premarin and Provera were the preferred ones. Currently, we're using transdermal low dose, molecularly identical. Recently, there was a speaker in town from the International Hormone Society, and NAMS, SOG, and Sigma all have a position statement that hormones are now safer, that timing is very critical. When a woman reaches menopause or a few years preceding or a few years after, that's the timing. Don't wait 10 years to initiate therapy. And doing an individual risk assessment to weigh the risks and benefits is absolutely essential. And once you've started her on treatment, it's imperative that you monitor as well and keep her on the lowest effective dose. Very briefly, we're going to go through a case, and this is a 52-year-old professor from UBC. She's very well informed. She's done all her reading. Severe vasomotor symptoms, insomnia, vaginal dryness, and low libido. She's perimenopausal because it's not been a year since her last period. Initially, mild symptoms, now severe. She finds it hard to teach in front of her students. And she comes in with a prescription for progesterone cream from her naturopath and said, well, my naturopath gave me this and it does help. So what would you tell her? And so now that you've been to this conference, you say, well, great, I can help you because I know that there are products that you might be interested in and you only want bioidentical, so I have something for you. So you discuss her family history and her risks and benefits, and you see that she's at risk for osteoporosis and coronary artery disease. So you can suggest a few of the transdermal products. You then spend some time talking to her about her lifestyle and putting in perspective that 2 drinks a day are actually a higher risk for breast cancer than hormone therapy ever was. So communicating risks and benefits, very important. You all are familiar with risk-benefit ratio. And I think as physicians, if you remain open and don't shut your patients out, and because our gut reaction is to say, oh gosh, bioidentical hormones, but just open up to that and engage them in a discussion and use that opportunity to discuss all the risks and benefits and educate them so they stay close and safe under your care. There was a study done in Vancouver, and women want to have the discussion with their doctors. They're scared. Many of them are on hormone therapy, and you don't even know about it. They're not telling you. They're getting it from the internet, and that's very dangerous. So open up and let them have that discussion. So the take-home message is basically they are synonymous. Bioidentical hormone therapy and molecular equivalency are exactly the same. And so use that terminology with them if that's the language they speak. But inside, we know that we have to use the FDA-approved products that are available to us that are molecular equivalents. Transdermal route is the best if you can use that. And customized compounding should be done very, very carefully under very strict guidelines. Thank you.
Thank you. Thank you for the organizers for inviting me here to speak today. It's obviously a topic that I'm very familiar with and have had a lot of experience in the last 11 years, so I hope I can share some insights with you today. And I just want to go through, I don't have any disclosures, no conflicts of interest, and no pharmaceutical grants or any other potential conflicts. So when I agreed to talk here, I got some learning objectives. It's a large topic to talk about perimenopause. I can't cover it in 15 minutes. But some of the questions that they wanted me to answer was really what was happening in perimenopause? What are the hormonal changes that are happening in the perimenopausal period? And what do those hormonal changes actually mean to the woman? What's happening in her life? And as well as what benefits does progesterone therapy offer for these symptoms in these women? And also at the end, we'll talk a little about risks and contraindications. So I hope I can take you on a little journey for perimenopause. I think the other two speakers have made it easier for me. They've covered a lot, but we'll just skip through that part and focus on what we can talk about progesterone therapy for perimenopausal symptoms. So, before our understanding of perimenopause, when we skipped from having regular menstrual cycles to going into menopause in this spectrum of perimenopause, what is it? We used to think, okay, it's a time where estrogen levels are declining. Well, that thinking has actually changed, and we now know that there's a lot of erratic high estrogen levels, and perimenopause is actually a time where we see three significant hormonal changes. We see erratic high estrogen levels, we see a decreased level in progesterone, and we also see a disturbed hypothalamic pituitary ovarian axis, which Dr. Rosengarten had talked about. And so with that, we can see that you're getting this hormonal milieu that's quite chaotic, and the feedback system, the feedback loops are not working as ideally as we'd like them to be. We do know that anovulation becomes more common, as Dr. Rosengarten mentioned, and in early perimenopause, some of the changes that we do see with regards to these changes that, again, shorter cycles, heavier flow, heavier bleeding, and as they transition towards menopause, that's when you're getting the skipped periods. Of course, you can have it at any time, but you're starting to decline your estrogens as you approach the menopausal transition. So it's really important to just get that picture, because typically, again, we always thought that there was all about estrogen deficiency or dropping estrogens. And if you can see in this diagram, and I'm sorry, I didn't realize I wasn't going to have a ability to point it out to you, but the pink graph is really women who are 18 to 30, 1836, before perimenopause, and you can see that the blue level is the perimenopausal women. The top figure shows estrogen levels, urinary estrogen levels, and they're significantly higher than the younger women. And then if you look down on the second graph there, it shows perimenopausal women in blue, and if you look at their progesterone levels, again, much, much lower. So there's a big shift in the hormone balance, in the estrogen-progesterone ratio that's occurring in perimenopausal women. And then this slide just shows you a similar thing, but over a period of time. If you look at the years of between the ages of 44 to 50, which is that typical perimenopausal time frame, with the average age of menopause being 51, you can see that estrogen levels are declining. Estrogen levels are much higher. Progesterone levels are declining overall. Again, just confirming that. And you can see that the FSH and LH are rising, but really just they cannot necessarily be predictive of what the other hormones, the estrogen and progesterone levels are dictating. So I like this graph because this actually, when I show some of this to my patients, they really get it and they understand what's happening. So the first slide is 6 months of regular menstrual cycles, okay? Everything flows nicely, all the estrogen, the progesterone, LH, FSH are all working in synchrony together, and you see a nice clear cycles. And then in perimenopause, with this disturbed HPO axis, the hypothalamic pituitary ovarian axis, and FSH and LH not working as optimally as we would like it to be with the feedback loop systems, we see that there's erratic estrogen, erratic progesterone, lower progesterone, And women feel this. Women say, I feel like I'm having PMS all the time. It's not just a week out of the month, it's all the time. And that's what their hormones are looking like. And of course, after perimenopause, the levels sort of flatten out. So, you can understand your women when they come in with all these symptoms, and, these symptoms are very familiar to you. I'm sure many of the women come in, and we sometimes don't know what to do with them, but they come in with, breast tenderness and heavy bleeding and long periods and heavy flow, dysmenorrhea, and that's often due to the, hormonal imbalances and the change in prostaglandin levels, with bloating, mood issues. You're familiar with all these lists here. And, I remember as a young graduate in 1991 and seeing one of my first perimenopausal women at that time, and she came in with acne and bleeding and hair loss and mood swings. And I actually don't know, and at that time, I'm dating myself, we weren't really allowed to give oral contraceptives over 35. So I remember that woman distinctly because I remember not having much to offer her. And other than, the oral contraceptive pill, but she was over 35 and we were not allowed to use that at that time. So we have a lot more options now, and we can actually help these women. And it's a very difficult time because, often when they're going through perimenopausal symptoms, their children are going through puberty. So it's a recipe for disaster. So we really need to help these women deal with these symptoms. Okay, so a little bit, that was about perimenopause, and those symptoms are really, dictated by increased estrogen as well as decreased progesterone. So when there's that imbalance that's happening, but I'm going to switch over and just talk about progesterone because that's really the topic of, that's the topic for discussion. And so when we look at progesterone, we have to remember that, and we all know that it's produced in the ovaries, it's also produced in the placenta, but it's also produced in the adrenal glands. And we used to think that progesterone has receptors in the uterus and the ovaries, and that was really all we were focused about. But we also now know in the research that progesterone receptors are everywhere. They exist in the brain, they exist in the lungs, they exist in bone, they exist in pancreatic islet cells. They're everywhere, right? So don't limit ourselves to the progesterone's effect on the body on just thinking it's on only for our endometrium. There is many more receptors in the body that respond to progesterone. As you know, the peak of progesterone occurs in the luteal phase, which we've already referred to. But interestingly, and if you go back to our biochemistry, I'm going to show you a diagram. We know that progesterone is also a steroid hormone. It's a steroid hormone, which is a precursor to other major steroid hormones, particularly cortisol and aldosterone. One of the things that we know is that progesterone balances estrogen. It counteracts the effect of estrogen. And interesting research that's now being looked at is progesterone's effect in the brain, and it's a neurosteroid. It actually helps inflammation in the brain. There's a large phase 3 clinical trial going on acute traumatic brain injury using progesterone, and they've actually found significant improvement in the people who were treated with progesterone, and that phase 3 trial is being conducted as we speak. So let's look at the steroid pathway, going back to biochemistry in medical school. We look at, if you can see, all steroid hormones are made from cholesterol. And we can see that the progesterone, if you can look at the pathways, progesterone is on your left there, you can see that progesterone is a precursor to aldosterone, and it's also a precursor to cortisol. It also makes hydroxyprogesterone, which filters all into the other androstenedione and other steroid hormones. So again, we're not going to talk in depth about that pathway, but remember that progesterone is at the top of that cascade, and so it's a very important hormone. So when we talk about progesterone therapy, what are the benefits? Why can we use, if we're going to use progesterone in menopause, what is it going to help? Well, we do know that the most significant symptoms that are often affected or benefited from progesterone is things like insomnia. It's not only the insomnia that falling to sleep insomnia, but it's the midnight awakening, like sleep awakening, where you're waking up in the middle of the night and you can't get back to sleep. Progesterone will help with that. Of course, sometimes it's not always the case and you need some estrogen as well. But in the perimenopausal phase, progesterone is very useful for sleep. And a lot of women, that's all they need, and it works really well. So, for me as a clinician, I've been able to use progesterone therapy and help women with a lot of their symptoms, sleep being one of them, and they've been able to go off their benzodiazepines or sleeping medications. Other symptoms that are effectively controlled are often night sweats. Dr. Rosengarten talked about bleeding. We do use progesterone for bleeding purposes, and I'll talk about that a little bit later. Fluid retention, progesterone is a natural diuretic. It helps with breast tenderness, brain fog. A lot of your women come in with that brain fog. Women do, again, the mechanisms is not quite known, but it does definitely help with that brain fog. A lot of women will find that their progesterone helps memory and helps that brain clarity. Headaches, it's very useful for hormonal headaches in perimenopause, because a lot of those headaches are due to the estrogen effect, and when progesterone balances out the estrogen, it really, really does help that. Mood swings and anxiety. Now, you have to remember, some of these symptoms can be due to the fluctuating estrogen level, so progesterone helps stabilize that, but if they're not taking care of it with the progesterone, sometimes it's an estrogen issue. So with progesterone therapy, with progesterone therapy, one of the things is we find that it's very effective with bleeding in anovulatory cycles for the heavy flow. And again, you have to use it much longer, not just in the 10 days if you're wanting to manage the heavier flow. We know that it, as I talked to there, it treats mid-cycle awakening with reduces, helping the REM sleep, and as well as, interestingly, when you're taking progesterone orally, the micronized progesterone orally, it is interacting with the GABA system, and that's why they think it's helping with sleep. So there's a brain effect and working with the GABA system in the brain. Very useful in some hormonal migraines. Again, I remember one of my patients who came to see me about, early in the practice of that I'm doing right now, and she'd been suffering for premenstrual migraine headaches for 11 years. And we treated her with progesterone, just cyclic progesterone in the latter part of her cycle. And in the first time in 11 years, she didn't have to take off work. She was able to function properly and go back, and, we got a dozen roses. So that's maybe a conflict of interest if I'm going to get roses. But no, if it works, it works really well. If it's not going to work, it's not going to work. But in women, if it's a hormonal headache, often the progesterone is a very useful tool, and it really significantly affects their life. Okay. Oh, I did want to mention one thing. One thing we do need to know is the data and the research for perimenopausal progesterone is quite limited. If you look at PubMed and if you look at all the literature for the research in this area, a lot of the research is in clinical and receptors and genetics, but the majority of the clinical research has actually been done by Geraldine Pryor at UBC, and she's actually been a very strong advocate of doing research in this area. And in fact, she's got an ongoing study. So right now she's recruiting participants, so for progesterone in perimenopause. So again, if you have patients, they would get free therapy, so I would urge you to support that study. But again, she has been quite strong in using her data to look at progesterone and has found very positive effects, which is what we were discussing today. So just a quick note about progesterone. So when we're talking about progesterone therapy, most of what I'm going to talk about is really progesterone. I think Dr. Pawa alluded to that there are differences between molecularly identical and non-molecularly identical. And when we talk about progesterone is the same as what's made from the ovary. So the ovary makes progesterone. We do have available standardized pharmaceutical grade progesterone. The progestins are different. So there's a class of drugs, progestogens, we have progesterone, and then we have progestogen. And progestogen, like Provera, is very similar to progesterone, but has a different molecular structure. And when we know with the research now, with explosive research on genetics and receptors and genetic coding, is that when these receptors are when these molecules are being bound by receptors, they have different actions on the same receptor. We know that Provera tends to be a little bit more androgenic, and it may be filtering down a little bit of a different pathway in that hormone cascade. So just to tell you here a little bit about what you might see in your practice. And I'm not saying that these are the therapies you should be using, but I'm just give you these pictures to show you what your patients, if they ever bring in any of their therapies, might have. Now, Prometrium we're very familiar with, and that's oral micronized progesterone. Standard pharmaceutical grade. It is a bioidentical or molecularly identical. So if your patient says, I want bioidentical progesterone, you can confidently give them Prometrium and say that, yes, this is bioidentical. And that's a really, useful tool because, again, as Dr. Pawa said, they'll come in asking for that. And rather than saying, well, I don't believe in bioidenticals, if we have a little bit of understanding that we can actually give them something that's safe, that we can use, that it's pharmaceutical grade, and that we have some evidence for. So Prometrium is a great source of oral micronized. And remember, progesterone, they have to micronize it because it's a very large molecule for it to get absorbed and for it to be utilized and bioavailable. The other things that you will see, the first one is a prescription of micronized progesterone cream. And again, remember, progesterone cream can't be used or won't be absorbed very well if it's not micronized, so it has to be a micronized progesterone cream. And this is typically what they're using when it's compounded via pharmacy. They come in, it's usually given in a syringe or that can be titrated so you can actually modify the dose. That's usually when people are getting it compounded by a trained pharmacist. And then the bottom one is a natural progesterone cream, and you've got to be very careful about this. May not have much side effects from that, but a lot of the times they're spending money on something that's not even being absorbed. It can be yam cream, and we know that yam is a large molecule, cannot be converted directly into progesterone without going through a process. And we don't know the dosing. Sometimes their patients are told to take a 1/4 teaspoon or an 1/8 teaspoon or a certain amount, and they just get used to just, I had one patient come in the other day, she says, I just take a big wallop and put it on my skin. And, we don't even know what dosing she's getting, don't know what's in it. And so I would really discourage, them to continuing that. And they'll tell you it helps. I mean, if it's true progesterone cream, it will help some of their symptoms. But you want to be able to say, well, I have something that we can actually look at the dosing and knowing exactly what you're getting. So just looking at it, what we just talked about, Prometrium is, the dosing can vary. We can use anywhere from 100 to 300. 300 is a little bit higher. We often have to use higher doses if there's a lot of bleeding going on. And then again, we'll talk a little bit about cyclic versus throughout the cycle. Depending on symptoms. And again, if there's used mostly for symptomatic control, particularly if most of their symptoms are premenstrual or in the latter part of their cycle, you can use the progesterone just in the latter part of the cycle. One of the challenges about oral micronized progesterone, which is Prometrium, is the fact that it's expensive when you get into the higher doses. And so if they have a drug plan, that's great. If they don't, it can be an issue. And that's where sometimes, experienced clinicians who are used to compounding or are used to working with a pharmacy that can compound it, the compounded form is much cheaper. So not your first line of, not your first choice, but if it's an issue, it's not that you don't have any other option for a woman. The other reason to compound, if you're going to use a micronized progesterone or a molecularly equivalent progesterone, the other reason would be if the woman has a peanut allergy, and because progesterone is or because Prometrium is made up with peanut oil, you cannot use a peanuts. You cannot use it in peanut allergies. Okay. Progesterone, Provera, we've talked about, Dr. Rosengarten's talked about. Just remember, it's not as good for some of the symptoms of perimenopause. It has a little bit of more mood issues, and I tend to find it not as well tolerated as the oral micronized progesterone. I put a quick note in there for progesterone cream. Again, not your first choice because, unless you're very familiar with it and you have a very trained pharmacist who's looking at it with, who's a PCCA pharmacist. He has to be trained in this and he has to have batch testing. But, they usually will use doses between 20 to 80 milligrams, and we won't go too much further in that. But just a note, because I do see this, please don't use or don't let your patients use progesterone cream when they do in menopause for uterine protection, for endometrial protection, because it's not safe enough, and we do get into trouble with women thinking that progesterone cream is safe for that. Okay, we talked about, I think this Dr. Rosengarten went over, just using it long, full cycle. If you're having bleeding issues, you can use it cyclically in 14 to 28 for perimenopausal symptoms, or a little bit longer. Some of the side effects, I don't see a lot of progesterone side effects, but typically, if you're going to get something, the more common ones are sedation, which is why it's helpful for sleep, sometimes a little bit of dizziness, a little bit of GI upset. Be careful and watch for depression, because if it happens, it'll happen fairly soon within the course of the treatment, and the woman will tell you, I feel worse and I feel depressed, and she'll tell you that. Most of the time, actually, it helps mood, and it helps them feel a lot better. Acne, again, often improves if it goes down the right pathway, but if it's starting to go down the androgen pathway, that will get worse. Okay, and the major contraindications we need to be aware of is hepatic dysfunction, if you've got a history of cancer, of a hormone-dependent cancer, endometrial hyperplasia, because you don't want to use it there, you really want to use a much more stronger progesterone and treatment for hyperplasia, history of stroke and DVT, and then you have to be careful if you have a classic migraine with aura. So last warning is just be careful what you say to a perimenopausal woman when she comes for your advice, and because you might get some outrage if you don't understand her symptoms. Thank you.